So I have no disclosures, um, and my objectives are to talk to you about geriatrics. I want to make sure that you consider prescribing, but mostly deprescribing in geriatric patients. The reason for this is as we age, we have special related changes, and we need to make sure that people are not having medications that they no longer need. And less is more is basically the story on this. But I want you to be able to coordinate and improve management and monitor prescription drugs to reduce polypharmacy and adverse drug events for patients, including inappropriate drugs like psychotropic drugs. So in my experience, I became a psychiatric nurse practitioner at Washington University in 1977. I actually have gone to a program for a residency at WashU for rural health. I became a geriatric and a family nurse practitioner at Mizzou in 1994. And with my geriatric nurse practitioner, I was doing it in hopes that I would be able to help my grandmother. But unfortunately, she passed away before I graduated. I owned one of the very first clinics that was an NP-owned clinic in Missouri, the Black River Health Center in Lesterville, Missouri, and I'm speaking to you now from the beautiful East Fork of the Black River. I also worked for St. Louis University in Project Hope. This was a HRSA grant that was established to provide care in a very impoverished county, which was Washington County. So I went into schools and did school health, where we made referrals for kids. We did hearing and vision and total physical assessments so that we could make referrals. I did psychiatric NP work in a strip mall, which is certainly a different way of doing it. And in order to meet community need for women's health, we had a traveling van, which we went to VFWs and churches and any group organization where we would need to be able to do women's health assessments. So it was a really interesting project, and it was very successful. We also did telehealth, which back then was a pretty up-and-coming thing, and it was linked to St. Louis University for psychiatry. I provided convenient care in Cape Girardeau at the St. Francis Health Center. I also started a clinic in Bonne Terre, Missouri through Midwest Health Group, and also worked in Farmington for them. I have practiced in the emergency room and also done correctional medicine. And most recently, I worked for the Missouri Quality Initiative in Long-Term Care for over 6 years. That is a Center of Medicaid and Medicare grant in which there were 7 states who also had same grant goals. So the goals of the grant were to reduce hospitalizations and long-term care by recognizing illness early, to get people to think about what they needed for advance directives, who would they want to speak for them if they were unable to speak for themselves, to eliminate antipsychotics in dementia unless somebody had a dual diagnosis, and also to reduce polypharmacy, which CMS considers to be more than 9 medications. So the 7 states all were in long-term care, and Missouri led nationally the 7 states, and my home, of which there were 16 in Missouri, led Missouri in the grant goals. We were successful. So the reason that it's important for the aging of America is that in 2019, there were 54 million older adults, but right now, baby boomers are turning 65 every single day and will for the next 10 years. And so knowing that, it's important to know that we're actually going to have 26% of the baby boomers, as they turn older, they will increase the aging of America by quite a bit. By 2030, all baby boomers will have turned 65, and then 18% of the US population will be at least 65, and that accounts for 72 million aging people. So if you're in family practice or any kind of a setting where you see elderly people, there's going to be a huge influx in the aging of America. CDC considers aging over 65, and many people who are 65 or older don't really require geriatric care. But there is, with this aging process, 20% of the people, or 40 million additional Medicare patients, will come on board by 2052. So advances in healthcare do help people to live longer, but aging makes us more vulnerable to chronic conditions and comorbidities. And everyone wants to live a long life, but no one really wants to be old. And Western medicine focuses more on disease, so it's important to try to prevent disability in this group. The state of health for geriatric United States residents are that 80% of elders have at least one chronic illness, and actually about 50% have two or more, with most having about 6 chronic conditions. So when you're assessing a geriatric patient and they have multiple comorbidities, it's really important to be able to know exactly what is going on with them and treat each person as an individual. Many people who have comorbidities also go to multiple providers, which also affects the mix. So every chronic condition has guidelines and recommendations for treatments. For the most common illnesses, and for all these guidelines, usually there are 1 to 3 medications recommended for each condition. And plus, people use over-the-counter medications. In addition to that, they also use herbal products. And so you need to be aware of medications that people are taking generally for all these different illnesses. With diabetes and hypertension, COPD, GERD, BPH, dementia, all of these medications are all the recommendations for these particular illnesses have increased the amount of prescribing that's done, and you can get potentially inappropriate prescribing. And CMS, as I said, considers 9 medications or more. So if you have someone who has 6 illnesses and they're each getting 1 to 3 medications, you're already maximizing the CMS recommendation of polypharmacy reduction of less than 9 medications. So when you have medications with an elderly population, a lot of things need to be taken into consideration that may not be taken into consideration with younger people. Patients can forget to take medications. They also can have, if they have timing of medications that are more than once a day, if they're BID or TID, that often causes problems with compliance. People oftentimes don't have assistance, or if people get medications set up in a medication dispenser, they might not be able to take those medications because of poor dexterity, particularly if giving something like insulin where it needs to be drawn up, or medication bottles. People have poor vision, so are they able to actually look at syringes or be able to read instructions because of vision issues? And a huge issue for the elderly is cost. So one thing that you need to take into consideration is what is the cost of a particular medication? Is this person going to not pay a utility bill or not buy food because of a cost of medication? Are they not going to buy the medication because of that? And now with mail reduction and slowing of the mail, people can sometimes have difficulty getting medications that are being mailed to them. So being able to treat multiple conditions rather than a single illness is really important. And you need to be able to assess each person as an individual. It's important to know what that particular person's goals are. Do they want to be aggressive about treating things, or do they want to step back and not take as many medications? So you want to look for modifiable factors as a broad approach. And once you reach age 60, dementia can double every 5 years. By 85, it's thought that either you have a 50-50 chance of having dementia or a 1 in 3 chance. Once people are having dementia, that's another consideration when you're giving out medications. Who's administering those? What is the ability of the person? Do they have any kind of a backup or a safety plan for having any kind of cognitive deficits? One of the things that you need to know is with this fast group growing over 85, rather than increasing longevity, we should be concerned about keeping people as functional as possible to reduce as much hands-on care as possible. So aging bodies actually react differently to medication. Absorption of medication doesn't really change, but aging body's absorption changes. So if you have increased fat stores and decreased water, that can impact absorption of medications. Hepatic blood flow can decrease medication clearance, and chronic disease and malnutrition can change albumin, causing higher blood protein-bound drugs. So you want to take into consideration everything that has to do with aging bodies as you're prescribing medications. And higher drug levels can cause toxicity in older people. So the main premise to remember in geriatrics is start with a low dose and go slow in increasing the dose, and take into consideration exactly what kind of benefit you have as opposed to a risk. Everything needs to be patient-centered and not always guideline-based. It's important to follow guidelines, but as I said, if you have multiple comorbidities and you're following guidelines, you're really giving an excessive amount of medications, and you want to try to give the least amount of medications for successful health for each particular person. So when you're evaluating medicines and you want to make sure that the benefit outweighs the risk, you want to be sure to look at what is the creatinine clearance in the GFR. You want to be able to assess the ability of these people to be able to excrete these medications. It's important to know the medication profiles of different medicines. If you're including that, you also want to know what is the impact of any kinds of medications that you're adding. And if you're adding any medications, you always want to try to look and see if there's something that could be removed. In deprescribing and discontinuing medications, you want to look to see if there's medications that are still appropriate. If you have someone who is 95 years old and a life expectancy is 5 years, you really probably don't need a statin medication. You also want to see if medications are still indicated. So if you have someone who has declined nutritionally and they're not eating as much, they may have weight loss, which may impact medications for diabetes. So you may have reductions in that. So there's lots of different aging changes that can cause you to consider discontinuing medications. It may no longer be in the goals of patients for patient care. And each individual plan needs to be based on values and, as I said, cognition. You need to assess what their comorbidities are. What is their lifestyle? How frail are they? There's actually an interesting app that can be used called Prognosis, where you can feed different data in for a particular patient, and it can tell you what the life expectancy for that person with those comorbidities could be. Gender makes a difference. Women tend to live longer than men. Ethnicity can also impact that. You also want to look at what the pill burden is, what the cost is, and what the socioeconomic issues are. We certainly don't want someone to not pay a utility bill or to not be able to purchase food because of costs of medicines. So if you're adding medications, being aware of what kind of insurance coverage people have, whether or not they're in the donut hole, and those kinds of issues can be really important to make sure that people are able to take what's being prescribed. Advance directives are an important thing to consider. It gives you a general idea of what that particular person's goals are. So do they want antibiotics if they're in end stage of life? Do they want to continue to take particular medications? Are they wanting to have aggressive care? So being aware of that and issuing or getting people to do advance directives gives you a general idea from family members and as well as patients as to what they would really like to have as their goals. 10% of geriatric patients actually live in poverty. And right now, that could even be different because of the COVID status. Some people aren't really initiating or going places or being involved in doing things. And so that number could actually be rising because of issues that we're having currently in our state of health in the entire United States. So once you decide that deprescribing should be a good issue for a particular patient, an explanation needs to be given to the patient and family of the plan so that they're on board and they understand why things are happening. And then you need to closely monitor outcomes of this. The Beers criteria list of 2015 is an excellent tool that will really help you know what medications are risky business for geriatric population. The reference for drug-to-drug interactions is a really good thing to take a look at. And it also gives you a good idea of renal dosing so that you know whether to reduce. So oftentimes, one thing that you can do is ask pharmacists to calculate what renal dosing would happen with a particular patient of yours if you can give them the lab data. You also need to be aware of things like anticholinergic drugs. They can be really offending medications. They can cause people to be confused. They can cause people to have blurred visions. You also need to take into consideration whether or not they have glaucoma. Tachycardia can be a side effect of that. They can develop angina from having anticholinergic effects. GERD could also be a problem. It can slow down the peristalsis, causing constipation. It can tighten urinary sphincters so that you would get urinary retention. And so there are lots of considerations with anticholinergic medications. And Beers actually gives you recommendations as alternatives for medications that you might want to decrease. So there are barriers to deprescribing. Often these cases are very complex, and so when you have a limited time in a clinical visit and you're only able to see someone for 15 minutes or so, just taking a look at a list of medications for 6 or more comorbidities could be a very difficult thing to do in that time frame. And when people go to multiple providers, you get fragmented care. And sometimes providers may not be aware of medications that are being prescribed by someone else. Lists could not be updated. People may have forgotten to bring something in. So you can certainly have information that's lacking. Patients' care goals are changing through their lifetime. And so it's really something that you need to know when you're trying to deprescribe. And it's difficult to assess sometimes if discontinuing is better and more of a benefit or a risk. So taking all these things into consideration with an individual, sometimes can cause a barrier. There are attitudes in the community and with professionals who think that more medications are better instead of less because they are trying to meet guidelines. For instance, I had a patient who was in the VA system, and they actually have incorporated guidelines into their EMR. And so a patient was having falls. And when we did an assessment on him, it was evident that he was getting orthostatic hypotension and falling and having injuries, including having to have staples for lacerations of the head and that sort of thing. And it's really difficult sometimes to get people to step back and look at the big picture and not try to just meet a guideline. But with the VA in particular, it was very difficult to get them to decide that this man was in jeopardy by taking all these different medications meeting guidelines, because it was causing other problems, which could actually cause more of a decline if he were to have a hip fracture or something like that. People also, when they're deprescribing, worry about the results of medications. What kind of withdrawal would someone have? So when you're taking people off medications, you want to make sure that you have an adequate plan in deprescribing, and that the reduction is slow and steady rather than just abruptly stopping a medication. For instance, if you're going to stop a medication for GERD, oftentimes to stop it abruptly, people would have a rebounding and they would have problems with having more issues instead of less. But if you were to give that medication every other day and then every third day over a long schedule, it would be a lot more effective than stopping something abruptly where someone realizes that they're having more side effects because of the withdrawal of that medication. And also, one of the barriers to deprescribing, as I said, is because of clinical guidelines. So the ADA recommendations are that if you're healthy, even if you're over 65, the expectancy is long, and you have a long life expectancy, you want to go ahead and have an A1C that's 7 to 7.5. But people who have moderate comorbidities and are thought to live a lesser time, you want to go ahead and loosen up what kind of A1C that you're going to be shooting for. Complex comorbidities of older people can be relaxed even more, because once you have tight control and it leads to hypoglycemia, people can certainly have issues and actually end up having more issues with low sugars than high sugars. So taking it in a particular situation for a person, you want to go ahead and look at what their A1C is and be more relaxed about it so that they don't have hypoglycemic episodes. People can have changes in appetites that may be something that even fluctuates throughout a day. So having medications that could cause their blood sugars to drop if they're not actually taking in good nutrition could cause falls and could cause hypoglycemia, and they could end up with a lot of problems and difficulty as a result of having low sugars instead of high. So whenever people add medications, you need to be aware that the medications are not being stacked or cascaded. So for example, when I first went into the long-term care facility, if someone was dizzy, the nurse would call and get a prescription for meclizine. If they were nauseated, instead of checking when their last bowel movement was, or blood sugar or blood pressure, they would call and get something for nausea. And so once these medications are being stacked on top of one another, and you're actually having issues with taking so many medications, it increases the number of medicines. And as I said, some of these medicines like anticholinergics can cause a lot of problems. So when people are taking over-the-counter Benadryl for sleep, or they're taking medications for overactive bladders, they can have also an increase of anticholinergic effects. And all of these things can cause problems, particularly if someone's living on their own and they're elderly. So polypharmacy causes drug-to-drug interactions. Side effects are often treated with another drug, as I just spoke to. And if a patient has 5 to 9 medications, they're already at a 50% increased chance to have drug interactions. Once you get to 20 medications or more, which many people are taking, they have up to 100% chance of interaction. People that add over-the-counter medications, they're sometimes not even listed in clinic records, or they're not noted by that person to know to report them. And any new medication should be evaluated before being added as to what kind of side effect it's going to have. I think that the free Hippocrates app is a very valuable tool, because you can actually go in and list a dozen medications on their interaction app, and you're able to look and see what kinds of medications are causing interactions. And if you're going to add a medication, it's a real convenient way to look and see what kind of impact it could have on what someone is already taking. Common drugs that cause adverse reactions are anticoagulants, NSAIDs, cardiovascular drugs, diuretics, antibiotics, anticonvulsants, and benzodiazepines. Also hypoglycemic agents. All of these can have problems that can cause elderly people a lot of side effects. NSAIDs, if they're used at very low doses for a short period of time, should probably be safe. But we know that if people don't eat well, or they don't take any kind of food or crackers or milk before they take a dose, it can certainly increase a chance of bleeds from ulcerations if they have that problem. And those should not be given for anyone who has any kind of a ulcer history. They also can reduce renal clearance and should not be given for anyone who has dialysis. They can cause cardiovascular toxicity. They can increase falls. They can cause psychiatric events and also increase stroke risk. Grapefruit with this CYP3A4 can cause a lot of problems with amiodarone. You can get toxicity, which can lead to a fatal ventricular dysrhythmia. It also, with verapamil, can cause a fatal arrhythmia. And simvastatin, it can increase the bioavailability, and you can get rhabdo. With CNS medications like antidepressants, benzodiazepines, opioids, muscle relaxers, antipsychotics, and anticholinergics, all of those can produce drowsiness and dizziness. And if you have those kinds of issues and people's blood pressures are dropping and they're hypotensive or sleeping more, they may not be eating as much as usual, they can have falls. So any of those medications are high risk in this population. Antihypertensive medicines can do the same thing. You can certainly have dizziness or orthostatic hypotension in general for any of these medications. So the medications, as was stated by Shanna, a lot of people are on PPIs. These medications in the elderly do put them at risk. So if they can be reduced slowly over time by spreading it out to every other day for a week or two, then every third day, then every fourth day, and just withdrawing people off of them, it can decrease the chance of C. diff infections. PPIs can cause bone loss, which can cause fractures. So these medicines are high risk for people. And then also, whenever you're using the anticoagulants or antiplatelet medications, you have increased bleed risk. So bleeding can be caused by frail skin, by falls, and so you just want to make sure that if someone is taking one of these medications, that they're not at risk for a bleed. Certainly, there are a lot of conditions that mandate that you take those medications, but if those are something that can be eliminated, that's a good choice. Digoxin doses rarely need to be above 1.25. You may not even need it for AFib if you can control it with other medicines. Beta blockers, diltiazem, verapamil, amiodarone, those medications can certainly make you be able to eliminate the digoxin dose. If you have too many drug interactions, it can cause toxicity. So amiodarone, colchicine, triazidone, tramadol, azithromycin, all of these medicines listed can change digoxin levels. So whenever you're initiating that drug, any new drug with it, you need to make sure that you know what your current level is, and then probably you should recheck in 72 hours. Tramadol is an interesting medication that I was unaware of at the time, and actually a couple of weeks after I recognized that it had a side effect of low sugar, there was an article put out about it. I had an elderly woman who was not acting her usual and had changes in cognition. And so the staff called me to let me know that she was not her usual self. And so we started checking everything. And I asked them to check her blood sugar, even though she was not diabetic. And it was found that she was hypoglycemic. And that is a side effect that can happen. So that's another consideration if you're using that medication. Vitamins and supplements really are unnecessary in older populations. They should be used if you're doing wound healing or if you're concerned about malnutrition. But once you start using them with warfarin and C and E, you could cause bleeds. And if you are going to change any medications, just make sure that you're tracking everything. Blood pressure medicines blood pressure monitoring should be done, but setting goals for people can be loosened up when you are dealing with the elderly population because of falls. A broken hip can result in mortality. So having systolic goals of 130 to 150, unless you have congestive heart failure, would be adequate to allow people to have higher numbers for their systolic reading. And also, if you have concerns about it, having a check of someone lying and standing 30 minutes after a meal would alert you to any kind of a dangerous change. So if someone has a pressure that drops more than 40 points when you are assessing it like this, or they have a systolic pressure that's less than 110, you certainly want to reduce medications. Also, blood pressure medicines sometimes can be reduced because of weight loss too, and people's pressures go down over time. One thing that I have noticed previously is particularly if people have many different providers and fragmented care is that more than one medication can be used for blood pressure. So trying to reduce medicines to the least amount of numbers of medications is vital because sometimes people would add medications on without having a maximum dose of the one that someone was currently on. Diuretics in an older population can not only cause people to dehydrate, but it also can cause people to have to use the bathroom more, and they have a chance of being incontinent, and that can cause falls as well. As long as you are using them short term, it's appropriate, but I would use the lowest dose and also make sure that you aren't interacting with other medications. Statins really do not need to be used with anyone who is having weight loss or is at end of life, and they shouldn't really be used for primary prevention in an older person. You know, as I said, if you have someone who's 92 or something, you're probably not really impacting them long term. Amiodarone and simvastatin combination can also cause rhabdo. There's lots of geriatric drug reactions that can happen. So you can have falls that can cause increase in morbidity and mortality. People with multiple drugs can get delirium. One of the physicians that I worked with that was our medical director had sent someone to the hospital, and the hospital had contacted the nursing home and requested that they fax over a list of the medicines, and the medication list wasn't sent over for a day or two. And when the physician made rounds and went into the room to talk to that person, the doctor said, how are you feeling? And he said, I'm feeling great. I haven't felt this way in a long time. And he said that he believed that it was because of the drug holiday that the patient was given, and that it actually improved his cognition, and medications were added on then very slowly. There are sometimes cognitive alterations that can be made from different medications. The anticholinergics I mentioned previously, but there are lots of side effects of any of the CNS medications that can impact. So certainly pain medications and minor tranquilizers and that sort of thing can cause lots and lots of issues with thinking. Incontinence can be an issue. Some medications can decrease fiber and fat soluble and B vitamins and minerals, and there are decreased nutritional status sometimes when people are taking lots of medications, and then when you add in over-the-counter medications, there's more of a risk. Hyponatremia can cause neural problems, which can decrease consciousness. It can disorient people. It can cause depression, seizures, and severe status can cause respiratory arrest. So be sure to know what kinds of medications cause hyponatremia. So that would be your diuretics, your SSRIs, and sometimes acetaminophen. So if you have less than 120 milligrams per deciliter, it's severe. The main side effects of polypharmacy are diabetes, malaise, anxiety, tremor, somnolence, pancreatitis, and it can even result in death. And so the concern for antipsychotic use in dementia is that it increases the risk of stroke, falls, dysphagia, and other neurological risks. There is no value in antipsychotics. They do not affect behavior, and they do not affect any kind of psychological symptoms. So if you have someone, a little old lady, every day at 3 o'clock, she's thinking that she needs to go check on her kids getting off the bus, it's not going to stop that. It's just a chemical restraint. And to restrain people with antipsychotics is, in my opinion, very inappropriate. CMS, as of 2010, showed that in nursing homes, 39.4% of residents nationwide that had no psychiatric diagnosis were giving antipsychotics for having issues with dementia. Antipsychotics are considered off-label. In 2005, it was known and became a black box warning. It increases morbidity and mortality by 1.6 to 1.7 times higher than those not taking antipsychotics. I think that it's a horrific thing to know that 20% or $1.7 million are spent on nursing home residents with atypical antipsychotics. I think that's shameful. So would you give this medication to your mother if it made her drink less well, eat less well, made her more agitated with akathisia, or if she had tardive dyskinesia, flycatcher tongue, was unable to eat or drink, had increased falling, which could cause hip fractures. She could have aspiration or aspiration pneumonia, and increases her dying chances by 10%, and it does not work for dementia. Now, certainly if someone is bipolar or schizophrenic, they would need to still have antipsychotics on board. So this particular patient was one that I presented to CMS, and she was 62 years old, morbidly obese with a BMI of 45.7 and a female. She had lots of different diagnoses. She had a post-polio muscle atrophy with chronic pain, depression, anxiety, kidney disease. She had UTIs, constipation, malaise, fatigue, CHF. She had an old MI. She had high cholesterol, sleep apnea. She had had breast cancer, osteoarthritis, paralysis of lower extremities, neuropathy, dysphagia, GERD, low vitamin D, and fibromyalgia. With all of these medications, or with all these diagnoses, which was 17, she had multiple medications prescribed for each, resulting in fatigue, confusion, hallucinations. She was incontinent of stool and urine and not participating in any life, unable to do activities of daily living, withdrawn, and very sleepy. These were her initial medications. So if you look at this list of 29 medications, there are multiple things that are replicated. So she was getting a barrage of medications. Just in creams, she was getting a bunch of medications besides oral medications. So the way that I always assess things when I'm trying to decide whether or not to deprescribe a medication is to look generally based on someone's diagnosis, lab, and assess their lab status at the time. So you want to make sure that their cognitive changes aren't coming from infection, or that they aren't having congestive failure, or they're not having problems with thyroid or their A1C, if they don't make sure they don't have a urinary tract infection. A lot of things get attributed to urinary tract infections when you're dealing with the elderly, but there can be a lot of things that are just drug related. So one of the first things when you have changes should be looking at drugs. So if you look at the classes of drugs, it can help you be able to eliminate different medicines. This woman had 7 medications for bowels, 5 for skin creams, 3 antidepressants. 1 was used for sleep, but whenever you're having all of these different medications and they're compounded, you're bound to get side effects. So in order to stay within my time limit, I'm going to let you know that the medications were reduced to this drug list. I was going to try to have a discussion of the case study, but rather than do that. So this woman still would be considered to have polypharmacy based on CMS's 9 medications being considered polypharmacy. But in her particular case, it was important that she have a lot of these medications because of the many comorbidities that she had. So once her medications were reduced, she was then back to eating and doing activities of daily living. She was continent of bowel and bladder. She was able to drive her electric wheelchair because her cognition had improved so dramatically. She was able to play bingo and lead Bible study group. But I will tell you that in our grant, she was one of the few people that elected to opt out because she preferred having lots of medications on board and was dedicated to having multiple benzodiazepines and pain medications. So what I'd like you to do is celebrate age, take into consideration each person. The most important thing is to try to keep people functional, not treat every particular illness with every guideline that's out there, and just try to appreciate that as people age, goals change, nutrition changes, and take all these things into consideration because less is more, and having medications be reduced is really the goal as you have people aging over time. And we all will have that in our practices as we see the increase in elderly people across the United States. And I thank you. Any questions?